So I'm excited to welcome our speaker today to talk to us about cancer survivorship care in primary care. Helen Tackitt joins us. She is a nurse practitioner, graduated from USF in 2002 with her BSN. She went on to attend Regis University to receive her MSN as an FNP. She has been board certified family nurse practitioner for almost 16 years. And in 2016, she did graduate from Regis University with her DNP. As a nurse practitioner, she spent 10 years working in urology and 5 years in oncology. She has over 11 years of progressive leadership experience, including working as the director of APRN PA for the Tackitt Cancer Institute at the Cleveland Clinic and the director of clinical practice and education at Duke Cancer Network. She has a passion for cancer survivors, which led her to opening direct primary care med in January of this year. So welcome, Helen. Thank you for speaking with us this afternoon. So outside of your professional bio, what's something personal, unique, or a hobby you'd like to share with our audience?
Yeah, thanks, Tammy. So I have 3 children. I spread them out 6-7 years apart so that I have one in car seats, one in diapers, one in daycare at a time because daycare is way too expensive. So my oldest is 23, my youngest is 10. And I love to hike in the outdoors.
Yeah, fun. And I'm sure getting those kids out to hike outdoors to get some of that energy out too.
Yeah, when I can force them.
Yes. So this is to show you our poll everywhere. This is an example question. You'll have a chance to test this out in a minute to make sure your poll everywhere is working. So cancer survivorship starts at diagnosis and continues through and beyond treatment. So true or false? I will read our disclosure questions and then we'll circle back to that poll everywhere question. So this activity has been planned and implemented under the sole supervision of the course director, Lee Berkowitz, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. Greensboro Area Health Education Center is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. The presenter has no relevant financial relationships with ineligible companies as defined by the ACCME. So let's test out your poll everywhere. Great. Thanks for the participation. Helen, how are they doing with 88% answering true?
So they're doing well because the cancer survivorship does start at time of diagnosis and then it goes beyond treatment. So for the rest of their life, they are considered a cancer survivor. So that is a true statement.
So I will turn the mic over to you, Helen. Thank you.
All right. Thank you, Tammy. And I'll just give a little more background. So at the Cleveland Clinic, Tackitt Cancer Institute, I was in charge of putting together their cancer survivorship program. And so I've been on the oncology side of the world in cancer survivorship. And then as Tammy mentioned, in January, I opened my own primary care practice. So now I'm on the other side of the world. And part of the reason why I opened this primary care practice is because it was exhausting to hear numerous times from different places on the oncology side that primary care providers don't know how to take care of cancer survivors. So hence the opening of my practice. So we're going to talk about that today. We're going to talk about what it looks like for primary care and their care of cancer survivors. So we think we already saw this in the poll practice question, but a cancer survivor, a person becomes a cancer survivor at the time of their diagnosis, and then it does continue throughout their lifetime. So there are over 17 million cancer survivors in the United States, and by 2040, the number is estimated to be 26.1 million. So why do we have this increase in cancer survivors? Well, it's because oncologists are so wonderful and they keep coming up with new treatments. And so we're improving these cancer screening and improving the treatments so people are living longer. And then the population is getting older. We have the baby boomers getting older, and then as people age, we know that they they can get more cancer or get cancer. And so that is the reason for this. And so hence, it's even more important for primary care to have involvement in cancer survivors, because there is no way that oncologists are going to be able to hold on to all of these cancer survivors. There are 3 phases of cancer survivorship. So there's the acute phase, which is also the active treatment phase, the extended phase, which is they recently had treatment that ended, and then the permanent phase, which is the rest of their life. So going into these phases a little more, so during the acute phase, the patients are undergoing active treatment. Their main concerns at that point is they don't feel good. They're having pain and fatigue and emotional distress. But the nice thing for them is they're at these wonderful cancer centers where they have all of this support. They have social work, they have nutrition, they have patient services. So there's a lot of support for them within that world of oncology. Then they go into the extended phase that the treatment is over. The patient faces then physical, psychological, and social readjustments. They usually are still seen at this point by the oncologist and that oncology team, so they still can have that support. But this is when their family is going, yay, they're ringing the bell, cancer's treatment is over, let's get back to normal life. But cancer survivors will tell you they don't know what normal life is. They don't know how to get back to normal life. And so at that point, tension sometimes occurs between the family and the friends and the patient, and they go through even more psychosocial distress at that point. And then there's the permanent phase. So patients should at this point have transitioned to primary care, and the struggles at this point are usually employment, health insurance, fears of secondary cancers, and late effects. So what do primary care providers know about cancer survivors? ASCO did a survey in 2019 of 117 primary care providers affiliated with a large academic medical center with 4 main focuses. Those focuses were current practices in cancer and care of cancer survivors, sense of preparedness to deliver such care, barriers to care of cancer survivors, and preferences for shared care and communication between the primary care providers and oncologists. And so what did they find out? They found out that primary care physicians are often involved in cancer survivorship, but many do not feel adequately prepared for the key components of it. I know that is probably not shocking to anybody listening to this presentation who currently works in oncology. 84% assume responsibility of complications from cancer therapy, but only 10% of primary care providers felt prepared to manage those complications. 65% felt unprepared to screen for late complications. 36% felt unprepared to screen for reoccurrence. And 94% assumed responsibility for managing and making referrals for psychological therapy, but only 25% felt prepared to take on those responsibilities. So patients, whether they're cancer patients or not, there's a lot of patients these days with anxiety and depression. Primary care sees this every day, multiple times a day. Primary care has very little training to deal with psychosocial, psychological issues with patients outside of maybe some mild depression, anxiety. And then we find ourselves at a loss for trying to refer. There's, at least today with COVID, I don't know what it was like before, but the psychiatrists, psychologists, counselors, clinical social workers are just bursting with patients. And so it is really hard to get patients in with these therapists. And sometimes if they need medication, they're going to need a psychiatrist. But of course, psychiatry doesn't do cognitive behavioral therapy. And so then you need a counselor. So it's really, primary care is left struggling of who is the best person for this patient to see. Do they need medications or do they just need counseling? And then trying to get them in. And then if they don't have insurance, then forget it, because it's even harder. And then Crabtree et al. Interviewed 38 clinicians in primary care practices. These all had national reputations as workforce innovators. And what they found is primary care thinks it's hard to stay current on cancer treatments. They described an uneasy relationship with oncologists. They have a lack of knowledge about cancer survivorship care. And none of the primary care providers interviewed had any knowledge of cancer survivorship guidelines. So why is this? Because oncology care is so complicated. It's an ever-evolving field with new treatments, complex therapies, as well as evolving genetic implications. For anybody on this Zoom webinar who's in oncology, think about how many conferences and CEs you get per year. Well, COC recommends that you have 12 a year anyway, but think about how many you get just to stay knowledgeable about treatment in your field. Primary care has to know a little bit about everything, and then you throw oncology on top of that. Primary care can't always keep up with the brand new cutting edge specialty treatments. It can be difficult for many providers to identify the side effects and reactions patients experience from chemotherapy or radiation treatments. And then to top it all off, if it's a follow-up patient, they get 15-minute appointment slot. So they're seeing about 30 patients a day, 15 minutes. 15 minutes is not a lot of time to address anything, let alone the numerous issues that you need to address with a cancer survivor. So cancer care is complicated. So we talked about this. Cancer survivorship care requires knowledge of toxicities, risks, long-term effects. So there's chemotherapy, immunotherapy, targeted therapy, hormone therapy, radiation, surgery. The list goes on, and there's always a new therapy that they're coming out with. I remember when the immunotherapies came out, and even on oncology, they didn't know what to do with all these IBISes. So just think about how primary care feels when they see a patient that has those issues. One physician said, cancer treatment kind of happens like in a black box. I feel a little intimidated by it. To be honest with you, I don't feel like I know enough about the long-term side effects of chemotoxic agents. So when I was at the Cleveland Clinic, I was responsible for training, or introducing, I should say, all of the new APPs to survivorship care, giving them their knowledge to be able to deal with cancer survivors as they were coming into the primary care clinics. And I tell you, they sat there and they were like deer in the headlights. They are so terrified. And I'll tell you, they basically just wanted to know what was the easiest way for them to get a hold of the oncologist because they were terrified to even try to think or learn all the different things they needed to in order to be taking care of these cancer survivorship patients. So here's a poll everywhere question. So what are the 3 phases of cancer survivorship?
How are they doing, Helen?
Well, they are doing good, Tammy. So 67% answered correctly at C. And I can say that I'm glad because the answer is actually on there and it says answer, which forgot to be taken off,
Yeah.
but not everybody saw that. So
gave you a little clue.
We'll see how the other slides are. So I may be giving it away of all my poll questions here. All right. And what percentage of primary care providers felt unprepared to screen for late complications? At least this one doesn't have the answer. Well, the answer is A, which is 65%. So everybody was a little bit almost equally split there, at least for a minute, but the answer is actually A. So we'll move on. So why do primary care providers struggle with cancer survivorship? Well, this slide says it all. So survivorship's not integrated into medical education. There are few continuing education programs for primary care. So there's lots for people in oncology, but as far as oncology to primary care, there is not that many. Patients lack the trust the primary care role in their survivorship care. So you hear this all the time. People do not want to leave their oncologist. They do not want to transition to primary care provider. They'll tell you, I don't think my primary care provider knows anything. Oncologists lack of trust in primary care. So I've heard that too, because I'm on the other side as well. And so I can't tell you, like I said, the number of times I've heard from oncology that primary care doesn't know what to do with our patients. And I can honestly say that they're not wrong in saying that. Emerging evidence regarding late effects and surveillance. So there's, like I said, there's always all these new treatments, new late effects, communication. So lack of consistent information from oncologists to primary care. So notes being sent from the oncologist to the primary care. I have an active treatment cancer patient that I have right now, and she has lymphoma, and she was sent to me for me to manage her steroid-induced hyperglycemia because she actually developed ITP, and I have yet to receive anything from her oncologist. So I actually have to rely on the patient to update me and to tell me what her blood sugars are. I've weaned her off of the metformin now because she's been weaned off of the steroids, but all the information I get from the patient. Lack of information from patients. So the information that I'm getting from my patient, she's really on top of it. And part of this is patients get these electronic medical records now. They can get in there, they can see their labs, which that's great. But some patients don't really have a understanding what's going on. So you're not going to get great information from them. Insufficient dissemination of clinical guidelines. So most often primary care isn't aware of the guidelines from oncology, and various use of medical records. So my medical records does not talk to Duke or UNC. I can get into UNC medical records. I can't get into Duke medical records. So if I have a patient at Duke, I have to rely on them to send me the old-fashioned way to fax me those records. Financial resources, so lack of time, clinical priorities. Like I said, these 15-minute appointments don't leave time for anything. Lack of reimbursement incentives, not traditionally targeted population for quality improvement, restrictions of insurance coverage, and lack of access to appropriate providers and services. I already talked about it's really hard for primary care to get them in, let's say, to psychologists and psychiatrists. So what are new primary care providers taught about cancer survivorship? Well, I went to the Harvard board review for internal medicine in December of 2021, and I was blown away that they only had a 1-hour course about cancer survivorship. Of that 1 hour, it was 30 minutes that were spent on running through quick guidelines and 30 minutes that was spent on psychosocial considerations. So they had a social worker talk for 30 minutes. They did cover breast, prostate, colorectal, and lung, so the main 4 that you'd see at regional practices. And they had basic follow-up labs and imaging for screening recurrence, so they ran through that with a brief mention of the most common side effects from radiation, chemotherapy, and surgery, but none of it was specific to any type of cancer. So it really didn't leave these new internal medicine providers knowing much about how to take care of cancer survivors. The survivorship core competencies, this is from the Journal of Oncology Practice, and so this is what they expect people to know to take care of survivorship patients. So they should demonstrate how to obtain a cancer and cancer treatment history and how to interpret the health implications, differentiate between common uses of the terms personal care, disease-free, overall survivor, survivorship, and cancer survivors, identify incidence and prevalence of cancer survivorship, overall differences by age and gender. And then for surveillance, understand the risk of new primary cancers, local or metastatic recurrence, be aware of available surveillance methods, be familiar with data on the impact of surveillance and early detection, and recognize treatment options and their effectiveness in the event of a new primary cancer or local or metastatic recurrence. So primary care is going to focus on colon cancer screening, breast cancer screening, prostate cancer screening. They should be focused on low-dose lung CT screening, although I can tell you that I don't think all of them are in tune to that at this point. But they might not know that if a patient had treatment for breast cancer, say radiation, that they are at risk for sarcoma. So primary care isn't going to always know of all of these secondary cancers that their patients are at risk for now based off some of the treatments they got for their primary cancer, unless the oncologist tells them, and so then they're clued in. So what's the solution? So ASCO tried to come up with a solution. They recognized the importance to provide survivorship care. And in 2004, they established a survivorship task force. Then in 2005, the Institute of Medicine had their landmark report From Cancer Patient to Cancer Survivor Lost in Transition. And I think most people have probably heard about that at some point. The Institute of Medicine describes survivorship care as a specific approach to monitoring and managing near, long-term, and late effects of cancer treatment and promoting health. The Institute of Medicine also identified the necessity of a cancer treatment summary and follow-up care plan known as the survivorship care plan. The Institute of Medicine identified 4 main parts of the survivorship care plan: preventing recurrent and new cancers as well as late effects of treatment, watching for cancer spread and secondary cancers, intervening to manage the consequences of cancer and its treatment, and coordinating specialists in primary care. So then what happened? In 2011, ASCO developed a committee on survivorship care. They defined the statements around survivorship care. They developed the templates for survivorship care plans, developed guidelines around survivorship care, outlined models of survivorship care, and developed a survivorship compendium to promote resources and tools for building and implementing a survivorship program. All that sounded wonderful and great, but then what happened? The survivorship care plan got pushed. Everybody's supposed to do this care plan. It's a patient-specific record that summarizes and communicates what happened during active treatment, recommendations for follow-up, surveillance testing, referrals for support services, information on short and long-term care. ASCO required at a minimum the survivorship care plan must include the recommended elements describing the treatment summary and a follow-up care plan. This is wonderful for primary care. So then in 2016, Commission on Cancer created Standard 3.3, which oncologists and clinics loathed because then they had to implement all these survivorship programs and everybody had to get a survivorship care plan. So the standard required that all patients receive a survivorship care plan if they received a curative intent for cancer treatment. So that meant the systems had to sit down and come up with what population of patients they considered curative intent who would receive a survivorship care plan. Programs could lose accreditation if this requirement was not met. All programs were supposed to gradually meet a goal of 100% of survivorship care plan delivery, and organizations started focusing on providing the care plan instead of delivering the information to the patient in the primary care. So I can tell you this was my role at the Cleveland Clinic, was to make sure that we were gradually able to get to 100% survivorship care plan. Wasn't my only job, but one of the many hats I wore. It took a lot of time, a lot of meetings to sit here and first determine what patients were considered curative intent, then find a database or some way for us to track these patients. So we made a REDCap database. Our tumor registry had to go through all of these patients, dump all this information into the REDCap database of the patients who needed survivorship care plans. The APPs then had to go through and make sure that every patient on that list had a survivorship care plan, or maybe they had progressed since then, so then they had to mark them as progressed. And I had to monitor all that to make sure everybody was doing what they were supposed to be doing. And then the APP spent an hour visit with patients to go through all this with them, sent that care plan to primary care. But then what happened? Primary care didn't know where to find it in the chart. Some didn't even know about it. So I tell you, at the Cleveland Clinic, when we had our COC accreditation, when they came to see our program, we actually got a deficiency on our survivorship care plans, as most places did. And so then what they did, we'll get to in a second, they did away with them. But because over time, several barriers in implementing the survivorship care plan emerged, it became clear that the current implementation of the survivorship care plan may not be achieved in their intended goals. 98% of primary care stated they wanted a survivorship care plan and follow-up care recommendations from the patient's oncologist, but only 11% received one. So that goes back to they couldn't find them. So in 2019, COC changed standard 3.3 to standard 4.8, which no longer requires a survivorship care plan to meet accreditation. That's great for all those oncology programs who are spending all this time and energy trying to do this, not so great for primary care. So now standard 4.8 can be met by having a survivorship program and a survivorship coordinator, documenting a minimum of 3 services offered to cancer survivors, which can include a survivorship care plan, but I don't know how many people are actually still doing that, seminars, referrals for nutrition, psychological, and rehab services. So I can tell you most of the clinics that I worked with through the Duke Cancer Network were not giving survivorship care plans, and we're focused more on those nutritional, psychological, and rehab services. So where does this leave primary care? Without the survivorship care plan, they're left guessing what to do with these cancer survivors in a 15-minute appointment that doesn't leave them a lot of time to try to figure things out. And so now we have another poll question.
So what do you guys think? The Institute of Medicine identified 4 main parts of survivorship care. Which answer below is not part of a survivorship care? A, preventing recurrent and new cancers as well as late effects of treatment. B, watching for cancer spread and secondary cancers. Or C, intervening to manage the consequences of cancer and its treatment. And D, screening for financial toxicity. And you guys have a hint.
Mm-hmm. All right. So it looks like most people ended up getting it, and it's screening for financial toxicity. It's a problem. It just was not part of what they implemented for survivorship care. All right, so going back to what PCPs are supposed to do now, survivorship care plans, as we stated, were time-consuming, hard to track for reporting for COC, so most programs gave them up, as I mentioned. NCCN has guidelines for survivorship care, but unless you're a member of NCCN, you cannot get these. So primary care can't access these guidelines. Like I said, and I doubt that they have NCCN memberships. PCPs, as I stated, don't have memberships, and even if they did, it's 291 pages. That would be very overwhelming. Comprehensive patient care management by the PCPs. So cancer survivors have a higher rate of comorbidities compared to the general population. Cancer patients need regular scheduled follow-up. Appointments focus on screening for reoccurrence, secondary cancers, prevention, and assessment of late effects. So these are very sick patients who need a lot of care. Primary care cannot do that in a 15-minute appointment. If they had a survivorship care plan, they might be able to focus in on a few key issues, which would be very helpful, but the whole care of the patient is about impossible in a 15-minute appointment. What should survivorship care look like from the primary care standpoint? Well, it should be screening for treatment and for tobacco cessation, Screening for treatment of alcohol and drug dependencies. What's their physical functioning like? What's the nutrition supporting guidance? What's their sexual health? Depression screening, anxiety screening. So these are all things that the NCCN says we should be doing for cancer survivors. And then we get the AYA population. So they have a lot of the same issues, except for them they have others. So they have body image disturbances, fertility concerns, financial toxicities. They all have financial toxicities. Peer relationships, work and career, and sexuality. Financial toxicities is a big thing for cancer survivors. It's a significant economic burden, even years after diagnosis. As many as 2 in 3 patients experience some level of financial toxicity. 25% of cancer survivors report using up all or most of their savings on treatment. 10% have problems paying their bills, their personal bills, and 8% delay or avoid care due to the cost of treatment. Among those filing for bankruptcy, the highest out-of-pocket medical expenses were associated with cancer compared to other diagnoses. One study suggests that cancer survivors over 65 or older were more likely to forego medical care due to costs. And another study found that 12% of cancer survivors reported being denied health or life insurance coverage because of their cancer diagnosis. Now, so another polling question. So what percentage of cancer survivors have difficulty paying their bills? A, 8%, B, 10%, C, 25%, or D, 50%? I threw a lot of percentages out there at everybody, but the answer to this is B, 10%. Accessibility. So patients are told that they're cured. Then they do not need to keep seeing their oncologist on a regular basis. But then what happens? They get psychological stress about this. They don't want to stop seeing their oncologist, who they trust, and lose support from their care team. Many do not have a primary care provider and have difficulty establishing with a local primary care. So how many people in oncology, how many of you APPs on this call have patients you want to transition to primary care? The patient then tells you, I don't have primary care. Because what happened? The patient gave up their primary care when they started their oncology treatment. They expected their oncologist to treat their high blood pressure and everything else too. And then now cancer treatment's over, you want to transition that patient to primary care. They tell you they don't have one. Where are all the primary care? They're full. A lot are not accepting new patients. I can tell you here in between Mebane, Graham, Hillsborough, very few are accepting new patients. If they are, patients have to wait at least 3 months to get in. And if they're sick and they call the primary care where they're established, there's not any appointments. So they end up being told to go to the emergency department or urgent care. So, and then once they establish with primary care, they don't have comfort a lot of times with the patient doesn't have comfort with the primary care, but then the primary care provider also doesn't have comfort treating and managing a complex cancer survivor patient. So how can oncology help? So oncology can really help primary care by completing that survivorship care plan. So even if your organization doesn't require as a COC requirement that you complete the survivorship care plan, the primary care provider would love to receive a survivorship care plan. And I'm sure the patient, I know I run a cancer support group, and they would love to have that copy of that survivorship care plan because cancer patients usually are pretty in tune to what's going on. And then educating local primary care providers about survivorship guidelines. So these symposia, conferences that we have in oncology oftentimes aren't to the level that they should be for educating primary care. So you're talking way over primary care's head a lot of times with these conferences. And so having conferences taught by the oncologists or the oncology APPs that are at the level that the primary care needs to know. So what do they need to know to take care of their patients? Although I can tell you that at Duke, we did a couple of these in the regional, some of the regional sites, and it's really hard to get the primary care providers to attend them because they're so busy with clinics. So once again, what can you do? All you can do is try, but somehow you have to get the primary care providers to actually show up. Trying to entice them with just that it's a CME conference doesn't always work. So I don't know if there's another way. And then reaching out to local primary care offices and establishing collaborative relationships. So the studies that I looked at showed that there's strained relationships oftentimes between the primary care provider and the oncologist. Primary care don't feel comfortable oftentimes calling the oncologist. And sometimes there's just a little bit of this turf war that goes on. So really reaching out and establishing those collaborative relationships so that primary care is comfortable calling and so they know who to call when there's a problem. I don't even know the one cancer patient I'm taking care of. I don't know her oncologist. I wouldn't know how to get a hold of her, even though I still technically work at Duke, and that's where she is. I do some temp work for them. And then establish the ability for primary care providers to have e-consults with oncologists. I know that some of the facilities that I've worked at do these e-consults, and that's also a great way to help primary care take care of the patients. So how can direct primary care MEBIN help? So I'm direct primary care MEBIN. I subspecialize in cancer survivorship care, as I've talked about. At my practice, all patients are scheduled for 60-minute appointments. Actually, I just changed my new patient appointments to 2 hours because I realized that 60 minutes wasn't enough for these complex patients, but all follow-up visits are scheduled at 60 minutes. I did implement the NCCN cancer survivorship guidelines, which I still have access to. So I did implement that into my care of these patients. All cancer survivors are screened with the PHQ-9 and the GAD for depression and anxiety. And I did reach out and establish relationships with counselors and psychologists who are comfortable with cancer survivors who I can refer these patients to if needed. And I offer same day, next day appointments. So I want to keep these patients out of the emergency department. We don't want these patients going there and catching anything else, especially if they're neutropenic. I have 2 chairs in my waiting room because people don't usually wait in the waiting room, so they're not going to be around other patients. And I am approved now as a nonprofit 501c3. So I am in the process of getting grants and raising money so that I can give free care to cancer survivors. So my goal is with the money that I can raise that it'll pay for the memberships for patients to see me and they'll get free care, which will help with their toxicity. And this is how you can contact me. Patients can go to the website. They can do a free meet and greet. There's my email address. So I'm going to turn it back over to Tammy and see if we have questions.
Thank you, Helen. So everyone, remember you can access Poll Everywhere and submit your questions to Helen. So I was jotting down some notes and a couple of your last slides highlighted. I think the one thing to highlight is how oncology providers can help communicate with primary care, because I do think, you know, in my practice, I have communicated with a lot of primary care providers much more frequently as I have a lot more survivors. The other thing that I have run into are cancer patients that may be out of treatment options. They're coming to big academic institutions, talk about financial toxicity if they live far away or paying for parking, and they don't want to sit in waiting rooms. So kind of end of life issues, and they're not quite at hospice yet. They could be kind of that in between. Where do you see the role of the primary care provider?
Yeah, so that's a tough one. So I'm going to tell you that primary care is not really equipped to help and transition those patients. I think the best thing that oncology can do is either, like you said, so if they're chronic treatment and not end of life, get palliative care involved to help with their symptom management. And of course, if they're more towards the end of life, nothing else can be done, transitioning to hospice. But primary care, of course, can see them for symptom management that comes up, but they're not, as you know, those patients had all kinds of psychosocial and other concerns. And really, you want to bring the family in with those types of patients. And so it really needs a whole team.
Yeah. So we have a question coming through. What strategies to promote coordination between primary care nurses and specialist oncology nurses do you have?
So I think it would be great. I know a lot of people have dedicated nurses for their care teams, and I think it would be really great if those nurses reached out to the nurses at the primary care office, just so that they know that they're there. Here's my phone number if you need help, you have questions, because like I said, when you get these patients that come in, you're like, oh my gosh, I don't know, who do I call? What's going on? Who do I ask a question to? And so that leads to a whole other level of stress in a busy day. And so if that nurse from the oncology office wanted to reach out, that would be amazing.
Yeah, the nursing, in both practices, I think could be really great resources, and lots of times really know these patients quite well.
Right.
Another question, how many patients do you see at your practice? It seems the need is far more than what you're able to provide. Do you think you will expand your practice?
So my practice is what's called a direct primary care practice. So I don't know how much you know about direct primary care, but there's about 1,600 of them in the United States, and there's about 8 or 9 or so around the Triangle area. And so it's a membership-based practice, which is what I want to try to get paid for the cancer patients. So between the ages of 18 to 64, it's $60 a month, and from 99 up, it's $99 a month, but it covers all of their care. So they can see me 5 times that month if they need to. I manage all their primary care needs. And so, but what happens in direct primary care is that we cap our patients. So I won't see any more than about 500 to 600 patients ever. And that's what allows me to continue to give the dedicated care to patients. If I were to ever get to that point, I'd have to make the decision to put them on a waiting list, as some direct primary care practices opt to do, or I'd have to hire another provider. So but that leaves me the ability to always be able to take care of and give my patients that dedicated care.
Yeah, one quick comment. I was really excited to see about the nonprofit, and I think that financial toxicity is a real barrier for patients, and they don't get care. And so I'm excited for you for that. So thanks for doing that.
Thank you. I'll let you know, Tammy, once I, have that money raised and can start taking those patients for free.
Yes, keep me posted. An additional question, as second survivors, what should be the care offered to family members of cancer survivors?
Yeah, so oftentimes family members get left out. And so I'll tell you, even so with the survivorship support group that I run that's at the church. So it's at Lamb's Chapel in Burlington, and I do it on the second and fourth Thursdays from 6:30 to 7:30, and all are welcome. So you don't have to be a member of Lamb's Chapel to attend the cancer support group there. And I do welcome in families But I do know that there are some support groups that do welcome in families, but most, because I've heard the complaints from places, from people, most are just for the patients and not for the family. And then the other thing I hear from people is most support groups are only for active treatment patients and not for cancer survivors. And so the people who have joined my support group let me know that they always felt left out at places because they weren't in active treatment. But yet they still have a lot of psychosocial issues that they don't know how to live that quote unquote normal life anymore.
Yeah, I spend an enormous amount of time talking with my patients about that aspect, and the resources that are out there for that particular subset of people is not very robust.
Exactly.
So this is not a question, it's a comment. I'm the Survivorship Program Coordinator at UNC, and I'm blown away by the steps you are taking to improve the care of these patients. Thank you. Please feel free to communicate with me in the future. I may be able to help with resources issues. So shout out to Melissa, our Survivorship Program Coordinator. So I will connect the two of you. Yeah, thank you, Melissa. I think that actually is great.
Yes, thank you. And I look forward to meeting you. Thank you, Tammy.
So other questions or even comments to the for Helen before we go figure out what's for dinner? So the so you're applying for grants. How else do you think you will raise money for that program?
So I've had Chickfila actually reach out to me. So I'm in some business meetings around here in Mebane. So at one of those meetings, when I announced the 501c3, there was a couple ladies, it was their first meeting from Chick-fil-A, and they actually came up to me and said they would love to host an event there, and then 10% of those proceeds will go towards the cancer survivorship funds. So I'm going to do something at Chick-fil-A. And then another lady who she works at State Farm, and she reached out to me to say that she also she does quarters for causes. And so she wants to do something as well. So that's just start, and then we'll see how it goes from there.
That's a pretty exciting start.
Yeah. So nice thing is usually people do want to help cancer patients. So I'm hoping that that we'll be able to get the funds to help quite a few cancers patients. And they don't have to be just a cancer. So anybody with cancer, so active treatments, cancer survivor, metastatic, whatever. I want to help all the cancer patients I can help. So as you can tell, I'm very passionate about that. So hopefully it'll all work out.
Yeah. So an additional comment, thank you so much. I'm attending from Spain and found it really interesting. Oh, hi. Welcome. Thank you for joining from Spain. So any closing things you want to stress to our audience today, Helen?
I mean, I think I've said it so many times that the importance of that survivorship care plan, but then actually making sure that the primary care provider got it, because I can't tell you how many times they said, well, I didn't get it, or they're in the same system. So at the Cleveland Clinic, so they all had Epic, so they were in the same system, but they didn't know where the care plan lived. So there wasn't an actual tab for a survivorship care plan. And so that was one of the other things we had to work on, was making sure they could find it, because you send it or you think that they can find it and they can't.
Yeah. I try to, I print a hard copy for all of my patients, and then encouraging them to take it to their PCP office too for those electronic glitches or lack of. So.
And I would say stressing to them that just because they're in oncology they shouldn't give up their relationship with their primary care, because trying to get back in, I mean, you're a new patient after 3 years, and then so trying to get back in, they may not accept you, or you may have to wait months. But I don't know any oncologists that are checking cholesterol, and who are doing some of these other things. They may be looking at their blood pressure. They may be, doing a blood sugar on them or something like that. Of course, they're doing a CMP probably in a CBC, but there are still other things that these patients need that the oncologists aren't doing. But patients think that the oncologists are doing everything. So I think it's important to stress to them to still keep that relationship with their primary care provider to make sure that everything else isn't falling through the cracks.
Yeah, I agree with that 110%.
And you don't want to see them for a sore throat, have they?
No, I don't.
No.
Or check their cholesterol.
Right, exactly.
Yes. All right, it looks like that's all the questions coming through. I will wrap up with our closing slide. So thank you all for attending. Thank you, Helen, for sharing your wisdom and stressing this important topic. Thank you to the University Cancer Research Fund, to the Lineberger Comprehensive Cancer Center, to the Cancer Network, and our amazing telehealth team. So you don't really see them, but without them, this is not possible. So thank you to Tim, Poe, Mary King, John Powell, Jason Paler, Benia Bjori, Oliver Marth, and Andrew Dodson.